Welcome back to the Deep Dive. We're here again to take those really dense foundational chapters, the ones that shape how we practice, and, well, break them down for you. Make them clear, easy to recall.
Yeah, ready for revision, ready for the real world.
Exactly. And today, it's a big one. Chapter 23 from Bailey and Love's Short Practice of Surgery, Anesthesia and Pain Relief.
Essential stuff. And this chapter, it really captures just how much this field has changed, how dynamic it is, how safety-focused.
So our mission today.
It's really to get beyond that basic idea of, just putting someone to sleep. We need to understand the anesthetist's role now as this perioperative physician.
Okay, perioperative physician, that sounds broad.
It is. It covers everything from checking the patient out beforehand, optimizing them for surgery, all the way through to managing their recovery, their pain, even chronic pain later on. The scope is huge.
Right. And to really get where we are now, I suppose we need to look back a bit. The history is actually pretty fascinating, isn't it? Full of controversies and breakthroughs.
Oh, absolutely. It's a great story. And modern anesthesia, it actually has a really specific birthday, you could say. October 16th, 1846.
That's specific. What happened?
That was the day William Morton, who was actually a dentist, gave the first really successful public demonstration of ether. It was at Massachusetts General in Boston.
Ah, the famous ether dome demo.
That's the one. He anesthetized a patient, Gilbert Abbott, so a surgeon could remove this large vascular tumor from his neck painlessly.
And that was the moment. The aha moment that convinced everyone.
Pretty much, yeah. It showed the surgical world very publicly that pain-free surgery wasn't just a dream. It was possible. But he wasn't the first person to try something, was he?
No, there were others sniffing around the edges, so to speak.
Right. Horace Wells, another dentist, funnily enough, 2 years before Morton, back in 1844, he'd been messing about with nitrous oxide.
Laughing gas.
Exactly. Humphrey Davy had already called it that way back in 1800. Wells used it for pulling teeth. He thought it worked, but his demonstrations, well, they didn't quite convince people in the same way Morton's did.
Why not? What was different about Morton's demo?
Morton achieved, or at least demonstrated, deep unconsciousness, not just, feeling a bit weird or having less sensation. That visible lack of response is what really kicked things off.
But even then, it wasn't like flipping a switch, was it? People didn't just immediately accept it everywhere.
No, not at all. There was huge pushback. A lot of it was religious, this idea that suffering, especially in childbirth, was divinely ordained. Interfering with that was seen as wrong.
A serious social barrier, then. How did that get overcome?
Royalty, actually. Chloroform came along, introduced by Sir James Young Simpson. It was a bit easier to handle than ether, but the real turning point was 1853.
What happened in 53?
Queen Victoria. She accepted chloroform during the birth of Prince Leopold. The man giving it was Dr. John Snow, another pioneer.
Ah, so if the Queen does it...
Exactly. Suddenly it's acceptable. It just dissolves those moral objections almost overnight. It gave pain relief a legitimacy that, no amount of scientific papers could have achieved at the time.
That's amazing. A single royal birth-shifting medical practice. High recall detail right there.
Definitely. And things kept moving, especially when they hit mechanical problems, particularly during wartime.
You mean like airway management?
Precisely. Fast forward to World War I. You've got these plastic surgery units dealing with horrific facial injuries. Two names stand out: Sir Ivan Magill and Stanley Rowbotham.
What did they develop?
They basically pioneered modern tracheal intubation, putting a tube into the windpipe. This allowed surgeons to actually work on these complex airway injuries without the anesthetic interfering, and vice versa. It separated the surgical field from the airway. A massive step.
And that happened around the same time as machines were being developed to deliver the gases.
Yeah, perfect timing, really. H.E.G. Boyle invented his continuous gas oxygen machine, the Boyle apparatus, in 1917. So you put together reliable delivery machines, safer agents, relatively speaking, and secure airway techniques.
And the specialty starts to properly form.
Absolutely. It matured quickly from there. The first diploma in anesthesia was offered in London only about 18 years later, in 1935.
Okay, that brings us nicely up to the modern era. So let's transition into part one. Key principles and the modern anesthetist. We touched on it, but let's really define this shift. The anesthetist isn't just the gas man anymore.
Not even close. The term now is perioperative physician, and it means responsibility for the whole patient journey through surgery.
The entire continuum, you said. So that starts way before the patient even sees the operating theater.
Definitely. Preoperative assessment is key. Is the patient as fit as they can be for this? Have we got their heart condition stable? Is their diabetes under control? What about their nutrition?
So it's about minimizing risk right from the outset.
Exactly. Optimizing them to withstand the stress of the operation and, just as importantly, to recover well afterwards. It makes a huge difference to outcomes, reduces complications, mortality.
And this focus on safety, on outcomes, it wasn't just doctors deciding to do better, was it? The system itself pushed for change through things like national audits.
Oh, hugely important. The chapter mentions NCE Pelode, the National Confidential Inquiry into Patient Outcome and Death, and the Confidential Inquiry into Maternal Deaths. These audits were, and still are, crucial.
What sort of things did they uncover?
They often shone a light on system failures. Things like poor communication between teams, delays in escalating care when a patient was deteriorating, maybe inadequate monitoring after emergency surgery.
So problems that needed system-level fixes, not just individual ones.
Exactly. It wasn't just about better training. It led to thinking about the whole pathway, standardizing care. That's where things like Enhanced Recovery After Surgery or ERAs programs came from.
And those rely heavily on teamwork.
Completely. Surgeon, anesthetists, nurses, physios, dietitians, everyone working together on a coordinated plan.
And maybe the most visible symbol of this safety culture, used everywhere now, is the WHO Surgical Safety Checklist. It seems so simple, almost low-tech compared to everything else. Why is it so effective?
Because it forces communication at critical points. The sign-in before induction, the timeout before the first cut, the sign-out at the end.
What does it actually check?
Simple but vital things.
Yeah.
Are we operating on the right patient? Is it the correct side, the correct procedure? Is all the equipment ready? Does everyone know the plan, especially if things might get tricky? Any expected heavy blood loss?
Just making sure everyone's on the same page.
Yes, and the evidence is overwhelming. Using it properly, religiously, dramatically cuts down on mistakes, on adverse events. It tackles human error head on.
Okay, before we dive into the drugs and techniques, we need that core definition. General anesthesia, or GA. It's defined by a triad, right? 3 essential components.
That's the foundation. You need all 3 for a balanced anesthetic. Number 1 is amnesia.
Meaning loss of awareness, unconsciousness.
Right. The patient must not remember the procedure. Number 2 is analgesia.
Pain relief.
Crucial, not just for comfort, but to block the body's stress response to the surgical trauma. That stress response can really destabilize things, especially the heart and circulation.
And the third part of the triad.
Muscle relaxation. This is often needed to give the surgeon good access, especially for abdominal or chest surgery. But, and this is key, if you give muscle relaxants, the patient can't breathe on their own.
So that necessitates artificial ventilation.
Absolutely. Control of the airway and breathing becomes entirely the anesthetist's job.
Okay, triad established. Amnesia, analgesia, muscle relaxation. Let's get into part 2. General anesthesia induction and maintenance. Starting with how we actually get the patient unconscious, the intravenous induction agents. You said this area has changed a lot.
Yeah, quite dramatically. For years, the go-to drug was thiopentone, a barbiturate. But now the standard, the workhorse, is propofol.
Why the switch? What makes propofol better?
Several things. It tends to give a smoother induction. Patients feel less hungover afterwards, and there's less nausea and vomiting, which is a big plus for recovery.
Okay, smoother, less sick. Anything else?
The big thing is its pharmacokinetics, how the body handles it. Propofol is cleared very quickly. It doesn't hang around or build up in the body fat like thiopentone did.
And why does that matter so much?
It means we can use it not just as a single shot to get someone off to sleep, but also as a continuous infusion to keep them anesthetized. And because it clears quickly, it has a short, context-sensitive aft time, patients wake up really fast and cleanly, even after hours of surgery.
Right, less grogginess, faster wake up. So, is there any reason to still use thiopentone at all?
Yes, there's one specific niche where it's still valuable, neurosurgery.
Neurosurgery, why there?
Okay, thiopentone does make the blood pressure drop, which isn't ideal, but it also does something useful in the brain. It reduces the brain's metabolic rate, its oxygen demand, and that helps lower intracranial pressure, or ICP.
So in patients with head injuries or brain tumors, lowering that pressure is critical.
Exactly. It helps maintain blood flow to the brain. So, in that specific context, the benefit of lowering ICP can outweigh the downside of the blood pressure drop. It's a trade-off.
Got it. What other 5E induction agents are there? Etomidate.
Yeah, etomidate. Its big selling point is hemodynamic stability. It hardly affects the heart rate or blood pressure at all.
Sounds ideal. Why isn't it used all the time then?
The concern is adrenocortical suppression. It can temporarily knock out the body's ability to produce cortisol, its natural stress hormone. So while it's great for a single induction dose, especially in someone cardiovascularly unstable, you generally avoid using it for long infusions.
Okay. And then there's ketamine. That one's quite different, isn't it?
Very different. It's a phencyclidine derivative chemically related to PCP. It produces what's called dissociative anesthesia. The patient looks sort of disconnected, not truly asleep in the same way as with propofol.
And its unique properties.
It's kind of the opposite of the others in some ways. It tends to maintain or even slightly increase blood pressure and heart rate. And crucially, patients usually keep breathing on their own.
So useful in specific situations.
Absolutely. Ideal for trauma situations out in the field, places where you might not have full monitoring or ventilation capabilities. Plus, it provides really potent pain relief itself.
Sounds great. What's the catch?
The main downside is emergence delirium. As patients wake up, they can have vivid dreams, hallucinations, sometimes quite unpleasant ones. We have ways to manage that, but it's something you always have to consider with ketamine.
Okay, so those are the main IV agents. Now, what about different ways of actually doing the induction? You mentioned specific techniques like inhalational induction and RSI.
Right. Inhalational induction is mostly for kids or maybe adults who are genuinely needle phobic. You use one of the inhaled anesthetic gases, usually sevoflurane because it doesn't smell too pungent, and the patient breathes it through a mask until they drift off.
Simpler for the patient maybe, but any downsides?
Well, it's slower, and you can lose control of the airway more easily during the process. It requires skill to manage that. It's not generally the first choice for adults unless there's a specific reason.
Then there's rapid sequence induction, RSI. The name says it all, it's fast. When is this absolutely necessary?
RSI is all about protecting the airway from aspiration. So you use it whenever there's a high risk that stomach contents could come up and go down into the lungs.
Like in emergencies.
Exactly. Emergency surgery is the classic indication. Also, patients with delayed stomach emptying, maybe from trauma, diabetes, pregnancy, or bowel obstruction, anyone considered to have a full stomach.
And what does the technique actually involve?
It's very specific. You pre-oxygenate the patient thoroughly. Then you give a pre-calculated dose of an IV induction agent, immediately followed by a fast-acting muscle relaxant, traditionally Suxamethonium, now often Rocuronium.
And no bagging in between.
No bag mask ventilation. That could inflate the stomach and increase the risk. As soon as the relaxant works, which is very quick, you perform laryngoscopy and intubate immediately, inflating the cuff on the tracheal tube to seal the airway. The whole sequence aims to secure the airway in under a minute. It's a critical safety drill.
Okay, so that's induction. What about keeping the patient anesthetized maintenance? Traditionally, that was inhaled gases, but you mentioned TIVA is getting more popular.
TIVA stands for Total Intravenous Anesthesia. And yes, its popularity has soared, largely thanks to propofol, combined with very short-acting opioids like remifentanil.
We already talked about propofol's good recovery profile. What are the other advantages driving the shift to TIVA?
Well, hemodynamic stability can be better, often smoother control of blood pressure. Recovery is consistently excellent. Patients wake up clear-headed. And a big factor now is the environmental concern.
Ah, the inhaled agents being greenhouse gases.
Exactly. Gases like sevoflurane, desflurane, isoflurane, they are potent greenhouse gases. Using TIVA completely avoids releasing these into the atmosphere. It's a significant environmental benefit that the specialty is taking very seriously.
So better recovery, potentially smoother course, and better for the planet. Are there specific types of surgery where TIVA is particularly useful?
Yes, definitely. Neurosurgery is when you want that fast, clear wake-up for neurological assessment. Surgery involving lasers in the airway. TIVA avoids flammable gases. Cardiopulmonary bypass surgery. And it's increasingly common for day case surgery where you want patients recovering quickly to go home.
Makes sense. But inhaled agents are still widely used for maintenance, isoflurane, sevoflurane, desflurane.
They are, yes. They're reliable, effective, easy to administer and monitor. Each has slightly different properties regarding speed of onset, offset, cost, and effects on circulation and breathing.
But one gas that used to be ubiquitous, nitrous oxide, is really falling out of favor. Why is that? It's been around forever.
N2O, yeah, laughing gas. It provides some pain relief and adds to the anesthetic effect. But its use is dropping off dramatically. There are several good reasons.
Here's this list.
Reason 1, post-operative nausea and vomiting PONV. Nitrous oxide is known to increase the risk of PONV quite significantly. If you're aiming for enhanced recovery, making patients feel sick is counterproductive.
Right. Reason 2.
It expands enclosed gas spaces. Nitrous is much more soluble in blood than nitrogen is, so it diffuses rapidly into any air-filled cavities in the body, like the middle ear, the bowel, or bubbles in the eye after certain types of eye surgery.
And that expansion can cause problems.
Big problems. It can increase pressure in the middle ear, potentially damage grafts in eye surgery, or worsen bowel distension. And in a trauma patient with a hidden pneumothorax air outside the lung using nitrous could rapidly turn it into a life-threatening tension pneumothorax.
Okay, that's serious. Reason 3.
Concerns about long-term effects, especially with prolonged exposure. It interferes with vitamin B12 metabolism, which is crucial for DNA synthesis. There are potential concerns about mutagenicity, although the clinical significance after typical anesthetic exposures is debated.
And the final nail in the coffin, similar to the other inhale agents.
Environment again. Nitrous oxide is a very potent greenhouse gas, hundreds of times worse than CO2, and it hangs around in the atmosphere for a long time. Reducing its use is a major environmental target for healthcare systems globally.
So PONV, gas expansion, potential B12 issues, and environment. It's a pretty compelling case for moving away from it.
Yeah, its role is becoming very limited now.
Okay, we've induced anesthesia, we're maintaining it.
Yep.
Now we need to tackle that crucial mechanical part, managing the airway, especially when muscle relaxants are used. Part 3, airway management and muscle relaxation.
This is core business for the anesthetist. Once you induce anesthesia, especially with relaxants, the patient loses muscle tone. The tongue falls back, blocks the airway, breathing stops.
So step 1 is basic maneuvers.
Yep. Head tilt, chin lift, jaw thrust. These simple actions lift the tongue and soft tissues off the back of the throat. You combine these with bag mask ventilation, squeezing oxygen into the lungs.
And you might use a simple adjunct like a Guedel airway.
Right, the oropharyngeal airway. It's just a curved piece of plastic that sits behind the tongue and holds it forward, keeping the airway open while you're bagging.
But it has a key limitation, doesn't it?
Absolutely. It helps with ventilation, but it offers zero protection against aspiration. If the patient regurgitates, stuff can still go straight down into the lungs, so it's only a temporary measure until you get a more secure airway in place.
And the big innovation for that intermediate level of security was the laryngeal mask airway, the LMA.
Developed by Dr. Archie Brain, a truly revolutionary device. It's a mask on the end of a tube that you slide into the back of the throat. The mask inflates and creates a seal around the top of the larynx, the glottic opening.
So it sits above the vocal cords, not through them like an ET tube.
Exactly. That means it's much less stimulating, less traumatic to insert than an endotracheal tube. It's also much easier to learn how to put one in. Paramedics, emergency staff can use them effectively.
But the original LMA, the classic LMA, has been superseded now by second-generation devices.
Largely, yes. Devices like the ProSeal LMA, the LMA Supreme, or the iGel. These second-generation supraglottic airways, or SGAs, have some key safety improvements.
What's the main difference?
The biggest one is an esophageal drain tube. It's a separate channel built into the device that runs down behind the mask sitting at the top of the esophagus.
And what does that do?
If any fluid or gas comes up from the stomach, it gets channeled away through this tube out into a drainage bag instead of pooling around the larynx where it could be aspirated. It's a major safety enhancement.
That sounds like a huge improvement. Any other features?
They often have a built-in bite block to stop the patient clamping down on the tube, and they generally form a better seal, allowing you to ventilate at slightly higher pressures. This makes them more suitable for, say, laparoscopic surgery or patients with a higher BMI.
So, better seal, aspiration protection. Seems like a win-win. Is there a version specifically designed for difficult airways?
Yes, the intubating LMA, or ILMA. It's basically an LMA designed as a conduit. Once it's in place, you can pass a special endotracheal tube through it, guided into the trachea, often without needing direct vision. It can be a lifesaver in a tricky situation.
But the gold standard for airway security remains endotracheal intubation, putting that tube right into the trachea.
It does, because once that tube is in place and the cuff below the vocal cords is inflated, you have a completely sealed system.
Yeah, that gives you two key things.
1, guaranteed ability to deliver positive pressure ventilation effectively. 2, definitive protection of the lungs from aspiration of any kind. Gastric contents, blood, secretions, nothing gets past that cuff.
But intubation isn't risk-free. It's a technical skill, and things can go wrong. What are the potential complications?
Oh, there's a list. Summary box 23.6 in the chapter covers them well. Immediately, you can fail to intubate. That's a crisis. You can damage teeth, lips, the larynx, vocal cords,
What about tube position?
You can accidentally intubate the esophagus instead of the trachea, disastrous if not recognized immediately via EtCO2 monitoring. Or you can push the tube too far down into one of the main bronchi, usually the right one.
And that means only one lung gets ventilated.
Right, the other one collapses. And aspiration can still happen during the intubation attempt itself before the cuff is up.
Those are immediate risks. What about later problems?
Sore throat is common. The tube itself can get blocked with secretions, kinked, or even disconnected from the ventilator circuit. And rarely, if the cuff pressure was too high or the intubation was prolonged, the patient can develop tracheal stenosis, a narrowing of the windpipe much later on.
The absolute nightmare scenario for an anesthetist is the can't intubate, can't oxygenate situation. What happens then? That's the ultimate airway emergency. You've tried to intubate, you've failed, you try to ventilate with a bag and mask, and you can't get oxygen in that way either. The patient's oxygen levels plummet. Brain damage or death can occur in minutes.
So you need backup plans and devices.
Absolutely. This is where things like video laryngoscopes come in. Devices like the McGrath, CM, and AirTrack. They have a tiny camera on the blade tip giving you a magnified, indirect view of the vocal cords on a screen.
Makes it easier to see where you're going.
Dramatically easier, especially in patients with difficult anatomy. They significantly improve first-pass success rates for intubation.
And if even that fails.
For the truly difficult, predicted or unpredicted airway, the ultimate tool is often the fiber-optic intubating bronchoscope.
How does that work?
It's a thin, flexible telescope. You thread the endotracheal tube over it, then you steer the scope down through the nose or mouth, visualizing the airway anatomy directly, find the vocal cords, pass the scope through them into the trachea, and then slide the tube down over the scope.
Sounds complex. Do you do that on an anesthetized patient?
Sometimes, but often, for the really tricky ones, it's done awake. You numb up the patient's airway thoroughly with local anesthetic spray and gel first. It requires a cooperative patient and a lot of skill, but it allows you to secure the airway under direct vision.
Wow, okay. And just briefly, there are special types of ET tubes for specific jobs, like double-lumen tubes.
Yeah, essential for thoracic surgery. If a surgeon needs to operate on one lung or needs it collapsed out of the way, a double-lumen tube allows us to ventilate the other lung normally while isolating and collapsing the operative lung, also used to isolate infection or bleeding in one lung.
Okay, airway secured. Now let's talk about the drugs that necessitate all this, the neuromuscular blocking agents or muscle relaxants, the third leg of the triad.
Right. Needed for surgical access makes intubation easier, but means we absolutely have to ventilate the patient. Two main types.
Depolarizing and non-depolarizing. Let's start with the classic depolarizing agent, Suxamethonium.
Also known as succinylcholine. It works by mimicking acetylcholine, the natural neurotransmitter, at the neuromuscular junction. It binds to the receptors and causes them to fire depolarize, leading to initial muscle twitches called fasciculations.
And then relaxation.
Yes. Then the membrane can't repolarize properly while suxamethonium is bound, leading to a flaccid paralysis. Its big advantage is speed.
Fastest onset.
By far. Works in about 30-60 seconds. And it wears off very quickly, too, usually within 5-10 minutes because it's broken down by an enzyme in the blood.
So ideal for RSI historically and for very short procedures.
Exactly. But the side effect profile is pretty significant.
What are the main worries with suxamethonium?
Okay, number one, hyperkalemia. It causes potassium to leak out of muscle cells. In patients with major burns, trauma, nerve injuries, or kidney failure, this potassium release can be massive, leading to cardiac arrest.
That's a major contraindication then? What else?
Muscle pains afterwards, quite common. Anaphylaxis, it's one of the more common triggers in anesthesia. And the big one, malignant hyperthermia. Suxamethonium is a primary trigger for this rare, inherited, life-threatening condition where metabolism goes into overdrive.
So fast and effective, but carry some serious baggage. Which leads us to the non-depolarizing agents.
Like Rocuronium, Vecuronium, Atracurium, Cisatracurium. These work differently. They are competitive antagonists.
Meaning they just block the receptor?
Yeah, they sit on the acetylcholine receptor but don't activate it. They just physically block acetylcholine from binding. So no fasciculations, just smooth onset of relaxation.
And their duration?
Generally longer and more predictable than suxamethonium, ranging from about 20 minutes to over an hour depending on the specific drug and dose. This makes them better suited for most routine surgical cases.
But because they last longer, you need to monitor the blockade and make sure it's worn off before waking the patient up.
Absolutely essential. We use a peripheral nerve stimulator, usually on the wrist or face, to deliver small electrical pulses and observe the muscle response that train for twitch monitoring. This tells us how much block is still present.
And you need reversal agents.
For most non-depolarizers, yes. The standard reversal uses an anticholinesterase drug, like neostigmine, combined with an anticholinergic, like glycopyrrolate, to counteract the side effects. Neostigmine stops the breakdown of acetylcholine, so more of it is around to compete with the blocking drug.
But Rocuronium has changed the game here, hasn't it? Because of Sugammadex.
Huge change. Sugammadex is a revolutionary drug. It's a modified cyclodextrin that directly encapsulates rocuronium and vecuronium molecules in the blood.
So it just mops it up.
Exactly. It pulls the rocuronium off the receptors, rapidly and completely reversing the block, even if it's a very deep block. Much faster and more reliable than neostigmine.
And this has implications for RSI.
Massive implications, because rocuronium has a reasonably fast onset, though not quite as fast as Suxamethonium, and can now be rapidly reversed with Sugammadex if needed, for example, if you couldn't intubate. It's become a valid and often safer alternative to Suxamethonium for RSI, avoiding all those Suxameth side effects.
Okay, so patient is relaxed, intubated, we need to ventilate them. Briefly, the main principles: volume control versus pressure control ventilation.
Two basic modes on the ventilator. With volume control, you set the specific tidal volume, the amount of air you want delivered with each breath. The ventilator pushes that volume in, and the pressure required will vary depending on how stiff the lungs are.
What's the risk there?
If the lungs become very stiff, say the patient's in Trendelenburg position, or they're obese or have lung disease, the pressure needed to deliver that set volume could become dangerously high. Risk of barotrauma lung injury from pressure, potentially causing a pneumothorax.
So pressure control is the alternative.
In pressure control, you set a maximum inspiratory pressure limit. The ventilator delivers flow until that pressure is reached, and then holds it for the set inspiratory time. The volume delivered will vary depending on the lung compliance and resistance.
What's the risk with pressure control?
The risk is inadequate ventilation. If the patient's lung compliance suddenly worsens, maybe they lose blood, or the surgeon puts packs in the abdomen, the volume delivered at that set pressure might drop significantly, leading to hypoventilation and rising CO2.
So both need careful monitoring. But regardless of the mode, you often add PEEP.
Yes, positive end expiratory pressure. It's really important. It means applying a small amount of positive pressure that's maintained in the airways, even at the end of the breath out.
Why do that? What does PEEP achieve?
It stops the tiny air sacs, the alveoli, from collapsing completely at the end of expiration. By keeping them splinted open, it increases the lung volume available for gas exchange, the functional residual capacity, or FRC.
And that helps oxygenation.
Significantly. It improves the matching of ventilation and perfusion, reduces shunting, blood passing through collapsed lung areas without picking up oxygen, and generally allows you to maintain good oxygen levels, often with a lower inspired oxygen concentration.
Okay. And watching over all of this complexity is the monitoring. What's the absolute basic mandatory monitoring during any general anesthetic?
There's a minimum standard: continuous ECG for heart rhythm, blood pressure, usually non-invasively with the cuff cycling regularly, inspired oxygen concentration analyzer, pulse oximetry, the SpO2 probe for oxygen saturation, and absolutely critical, capnography, measuring end-tidal carbon dioxide, EtCO2.
Why is EtCO2 so vital?
It confirms the endotracheal tube is in the trachea, not the esophagus. It confirms ongoing ventilation and circulation. Changes in EtCO2 can be the earliest sign of many critical problems, like disconnection, obstruction, or even cardiac arrest.
And for bigger operations?
You add more invasive monitoring. Maybe an arterial line for beat-to-beat blood pressure and blood gas sampling, a urinary catheter to measure urine output reflecting kidney perfusion, sometimes central venous pressure monitoring via a line in a large neck vein. These layers of monitoring are the safety net.
Right, makes sense. Okay, let's shift gears now away from GA Part 4. Local and regional anesthesia. This is a huge area aiming to block pain signals at the source. But we have to start with safety, local anesthetic drugs, and toxicity.
Absolutely paramount. Local anesthetics LAs work by blocking sodium channels and nerve membranes, stopping them from conducting impulses. Great when it's where you want it, very bad if too much gets into the bloodstream.
We have different LAs. The common ones are lidocaine and bupivacaine. How do they differ?
Lidocaine is sort of the prototype. It works quickly but doesn't last that long. Maximum safe dose is around 3 milligrams per kilogram body weight, or up to 7 kilograms if you add adrenaline to it.
And bupivacaine.
Bupivacaine lasts much longer, which is great for post-op pain relief.
Yeah.
But, and this is the critical point, it is significantly more cardiotoxic than lidocaine.
Cardiotoxic. What happens if you accidentally inject bupivacaine into a vein?
It can cause severe, often treatment-resistant ventricular arrhythmias, dangerous heart rhythms, and even complete cardiac arrest. It binds very tightly to cardiac sodium channels. This is why the absolute rule is bupivacaine must never be used for intravenous regional anesthesia, like a Beers block, and extreme care must be taken with dosage calculation and injection technique for any block.
Are there warning signs before the heart stops? Neurological signs?
Yes, thankfully. Systemic toxicity usually presents with neurological symptoms first. The patient might complain of numbness around the mouth or tongue, a metallic taste, ringing in the ears, tinnitus, or visual disturbances.
And if it progresses?
Then you get muscle twitching, confusions, seizures, eventually unconsciousness, respiratory arrest, and finally cardiovascular collapse. Recognizing those early CNS signs is crucial. Stop injecting immediately.
You mentioned adding adrenaline or epinephrine. Why do we do that?
Adrenaline causes local vasoconstriction. It narrows the blood vessels where you inject. This slows down the absorption of the LA into the bloodstream.
Wait, me.
It keeps the LA concentrated at the nerve for longer, so the block lasts longer. It can also make the block set in a bit faster. And because less is absorbed systemically at once, it allows you to use a slightly higher total dose of the LA safely.
But there are situations where you absolutely should not use adrenaline.
Definitely. 3 main ones. 1, patients with significant cardiovascular disease where the adrenaline itself could cause problems. 2, patients on certain interacting drugs like MAO inhibitors or tricyclic antidepressants.
And the third one is anatomical.
Yes, the classic one. Never inject adrenaline-containing solutions into body parts supplied by end arteries. That means fingers, toes, the nose, ears, and the penis. The vasoconstriction could be so intense it cuts off the blood supply completely and causes tissue necrosis, gangrene.
Right. Very important rule. Given these risks, what's the essential safety backup whenever you're doing any regional block?
You must have immediate access to full resuscitation equipment, oxygen, airway gear, emergency drugs, defibrillator, and staff trained in advanced life support, including the specific management of LA systemic toxicity, which involves using an intravenous lipid emulsion called intralipid. It's rare, but you have to be prepared.
This focus on safety has driven changes in how blocks are performed, moving beyond just anatomy.
Yeah, the days of just aiming for a landmark and hoping for paresthesia, that electric shock feeling, are largely gone. We moved to using nerve stimulators for a while, which cause a muscle twitch when the needle's close to a motor nerve.
But the real revolution has been ultrasound.
Ultrasound-guided regional anesthesia. It's transformed the practice.
How so? What does ultrasound let you do?
You can actually see everything in real time. You see the needle approaching the nerve bundle. You see the nerves themselves, often looking like a honeycomb. You see the arteries and veins you need to avoid. And you see the local anesthetic spreading around the nerve as you inject it.
So much more precise and safer.
Massively. Better success rates, fewer complications like nerve damage or hitting a blood vessel. And because you can see exactly where the LA is going, you can often use smaller volumes, further increasing safety. It's become the standard of care for most blocks.
Okay, let's talk specifics. Upper limb blocks, targeting the brachial plexus. Where do you block it for shoulder surgery?
For the shoulder, the interscalene block is common. You inject high up in the neck, between the scalene muscles where the nerve roots emerge. Very effective block for shoulder work.
But it has some well-known side effects.
Yes, because of the anatomy there. The phrenic nerve, which controls the diaphragm on that side, runs right past, so you almost always get temporary paralysis of that half of the diaphragm. Patients need warning. They might feel a bit short of breath. You can also get a temporary Horner syndrome, droopy eyelid, small pupil from blocking nearby sympathetic nerves.
So maybe not ideal for someone with severe lung disease. Where else can you block the brachial plexus?
Further down, you can do supraclavicular, infraclavicular, or axillary blocks, depending on whether you need to cover the whole arm, forearm, or just the hand. Ultrasound makes these much safer than they used to be.
Lower limb, femoral and sciatic are the big ones.
They are the main nerves supplying the leg, yes. Blocking them provides anesthesia for major leg surgery, but there's a trend towards more specific blocks, especially for things like knee surgery, that aim for pain relief without as much muscle weakness.
Like the IPAC block you mentioned.
Yeah, the IPAC infiltration between the popliteal artery and capsule of the knee. It specifically targets the sensory nerves supplying the back of the knee joint capsule. Good pain relief after knee replacement, but leaves the major muscles working better so patients can potentially mobilize earlier.
And another rapidly growing area is fascial plane blocks, especially for trunk and abdominal surgery. What's the principle?
The idea is you inject a larger volume of dilute LA into a specific tissue plane between layers of muscle or fascia where nerves supplying a region are known to travel. The LA then spreads along that plane and bathes the nerves.
The classic example being the TAPI block.
Transversus abdominis plane block. You inject LA into the plane between the internal oblique muscle and the transversus abdominis muscle in the side of the abdominal wall.
And what nerves does that get?
It blocks the segmental nerves, roughly T6 to L1, that supply the skin and muscles of the anterior abdominal wall. So it's great for reducing pain from the incision after things like C-sections, hernia repairs, appendectomies. Really helps cut down on opioid use.
Are there others like the TP block?
Yes, lots are being developed. Quadratus lumborum, QL blocks. Erector spinae plane, ESP blocks. They target different planes and potentially provide broader coverage, sometimes including visceral pain from inside the abdomen. Ultrasound is absolutely essential for these.
Okay, one more technique. Intravenous regional anesthesia, or Beer's block. Still used.
Yes, for short procedures on the arm or hand, like carpal tunnel release, it's quite elegant in a way.
Remind us how it works. Double tourniquet.
Right. Put a double cuff tourniquet high on the arm, then you exsanguinate the arm, squeeze all the blood out, usually with a tight rubber S-march bandage wrapped from fingers to tourniquet. Inflate the proximal cuff, the one higher up the arm, to well above systolic pressure.
Then inject the LA.
Yes, inject the LA into a vein in the back of a hand or forearm. Because the tourniquet is up, the LA fills the limb's venous system and diffuses out into the tissues, numbing everything below the cuff.
You mentioned bupivacaine is an absolute no-no. Which drug is used?
Prilocaine is the standard agent. It's less cardiotoxic than bupivacaine should any leak past the cuff.
And the critical time rule.
You must keep the cuff inflated for a minimum of 20 minutes, even if the surgery finishes sooner. This gives the prilocaine time to bind to the tissues so you don't get a sudden, dangerous washout into the systemic circulation when you release the cuff. Then you deflate the cuff slowly.
Okay. Lastly, in regional, the central neuraxial blocks, spinal and epidural. How do they differ?
Both involve injections near the spinal cord, but into different spaces. Spinal anesthesia is an injection directly into the cerebrospinal fluid, CSF, in the intrathecal space, usually with a very fine needle.
What kind of block does that give?
A very rapid, dense, and reliable block. Great for lower limb surgery, hip replacements, C-sections, usually a single shot.
Downsides of spinal.
The main one is hypotension, a drop in blood pressure, because it blocks the sympathetic nerves quite profoundly, especially if the block goes high, above T10, it causes vasodilation. Also, risk of post-dural puncture headache, PDPH, though much less common now with fine pencil point needles that spread dural fibers rather than cutting them.
And epidurals, where does the needle go?
An epidural involves placing a needle into the epidural space, which is outside the dura mater, the membrane surrounding the spinal cord and CSF. You don't puncture the dura.
Slower onset than spinal.
Yes, slower onset, often less dense block initially, but the huge advantage is you can thread a fine catheter through the epidural needle and leave it in place.
For continuous infusion.
Exactly. You can give top-up doses or run a continuous infusion of LA, often mixed with a small amount of opioid, for hours or even days. This provides excellent prolonged pain relief, famously used in childbirth, but also fantastic for postoperative pain after major surgery.
Does epidural cause less hypotension than spinal?
Generally, yes, the onset is slower, so the body compensates better. And because you can place the catheter at different levels, for example, thoracic epidural for chest or upper abdominal surgery, you can tailor the block more.
Any downsides to epidurals?
Technically more difficult to perform than spinals, higher failure rate, slightly higher risk of complications like nerve damage or epidural hematoma, a collection of blood, or abscess, though these are rare.
Okay, that covers the main regional techniques, which leads us perfectly into part 5, pain management. Starting with acute post-operative pain. How do we define pain?
The official IASP definition is important. An unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage. Note the emotional experience part. Pain isn't just a sensation.
And the modern strategy for tackling acute pain isn't just about giving morphine.
No, definitely not. The cornerstone is multimodal analgesia, using a combination of different types of painkillers, working by different mechanisms, often including regional anesthesia techniques we just discussed,
What's the goal of the multimodal approach?
to achieve good pain relief while minimizing the dose and therefore the side effects of any single type of drug, particularly strong opioids.
So what are the components? Paracetamol.
Paracetamol, or acetaminophen in the US, is usually the baseline. It's step 1 on the WHO analgesic ladder. Surprisingly complex history made in the 1870s, but only widely used after the 50s when a related drug, phenacetin, was pulled for kidney damage.
We think of it as simple, but timing matters post-op.
Yeah, oral or rectal paracetamol can take 40-60 minutes to work well, and absorption can be erratic. The IV preparation is a big help here, gives reliable, fast onset, making it a dependable part of the immediate post-op plan.
Then we have NSAIDs, non-steroidal anti-inflammatory drugs.
Like ibuprofen, diclofenac, ketorolac, they're very effective analgesics, especially for inflammatory pain, and great opioid-sparing agents.
But they come with significant warnings.
They do. You have to use them cautiously. They can increase bleeding risk, cause GI ulcers or bleeding, impair kidney function, especially in dehydrated or elderly patients, worsen asthma, and some carry a risk of cardiovascular events like heart attack or stroke with prolonged use. So weigh the risks and benefits carefully for each patient.
And finally, the opioids.
Right.
From weaker ones like codeine to strong ones like morphine, oxycodone, fentanyl.
Still essential for moderate to severe acute pain, but the multimodal approach aims to keep the opioid dose as low as possible to avoid the well-known side effects.
Which are mainly
Nausea and vomiting are very common, itching, pruritus, constipation, sedation, and the most feared one, respiratory depression, slowing down breathing, potentially dangerously so at high doses.
a common way to give strong opioids post-op is PCA, patient-controlled analgesia. How does that work?
The patient have a button connected to a pump containing the opioid, for example, morphine. When they feel pain, they press the button and get a small preset bolus dose delivered intravenously.
But there are safety limits built in.
Absolutely. The doctor programs the pump with the size of the dose, a lockout interval, for example, they can only get a dose every 5 minutes, and often a maximum total dose per hour.
Why is PCA so popular?
Patients feel more in control. They can treat their pain when it starts, rather than waiting for a nurse. This often leads to better pain relief overall, sometimes even with a lower total opioid consumption compared to nurse-administered as-needed injections.
Okay, that's acute pain. Now, the much tougher challenge. Chronic pain syndromes. Pain lasting longer than 3 months.
Yeah, chronic pain is a different beast. It's not just prolonged acute pain. The nervous system itself often changes and becomes dysfunctional.
How is it classified? Primary versus secondary.
Chronic primary pain is where the pain itself is considered the main disease, like fibromyalgia or chronic low back pain where no specific cause is found. Chronic secondary pain is pain that's a symptom of another underlying condition, like cancer pain, pain from nerve damage, neuropathic pain, or persistent post-surgical pain.
To treat it effectively, we need to understand the type of pain. The chapter distinguishes nociceptive versus neuropathic.
Crucial distinction. Nociceptive pain is caused by ongoing activation of normal pain receptors, nociceptors, in tissues, muscle, bone, joints, organs. Think arthritis pain or pain from a tumor pressing on structures.
And if that goes on long enough?
It can lead to central sensitization. The spinal cord and brain essentially learn the pain and become hyperexcitable. The volume knob for pain gets turned up.
Resulting in
Hyperalgesia, things that should hurt a little now hurt a lot. And allodynia, things that shouldn't hurt at all, like light touch or clothing, now cause pain.
Okay, that's nociceptive pain with sensitization. What's neuropathic pain?
This results from damage or disease affecting the nervous system itself, peripheral nerves, spinal cord, or brain. The nerves themselves are misfiring or sending abnormal signals.
How do patients typically describe neuropathic pain?
The descriptions are often quite distinct. Burning, shooting, stabbing, tingling, pins and needles, electric shocks. Classic examples are trigeminal neuralgia, diabetic neuropathy, post-herpetic neuralgia, shingles pain.
And the key clinical point about neuropathic pain.
It often responds poorly to traditional painkillers like opioids and NSAIDs. The underlying mechanism is different, so you need different types of drugs.
This complexity means managing chronic pain requires a different model, doesn't it? The biopsychosocial model.
Absolutely. based on Melzack and Wall's gate control theory, which recognized pain has sensory, motivational, and cognitive aspects. The biopsychosocial model accepts that chronic pain is influenced by biological factors, the injury disease, psychological factors, mood, anxiety, beliefs, coping strategies, and social factors, work, family, support systems.
So treatment can't just be pills, it needs to be multidisciplinary.
Exactly. Non-pharmacological approaches are vital. Physiotherapy, graded exercise programs are key to combat deconditioning.
And the psychological side.
Hugely important. Psychological therapies like cognitive behavioral therapy, CBT, help patients change unhelpful thought patterns and behaviors related to their pain. Mindfulness, acceptance, and commitment therapy, ACT, counseling all can play a role, often delivered through structured pain management programs.
Okay, what about drugs for chronic pain? If opioids aren't great for neuropathic pain, what is used?
The mainstay drugs for neuropathic pain are actually anticonvulsants, specifically gabapentin and pregabalin, and certain types of antidepressants, particularly tricyclics like amitriptyline and SNRIs like duloxetine.
How do the anticonvulsants work?
They are thought to work by binding to specific subunits of calcium channels on nerve cells, reducing the release of excitatory neurotransmitters, basically calming down the hyper-excitable nerves.
And antidepressants, they're not just for depression.
No, they have direct pain-relieving effects, particularly for neuropathic pain, separate from their effects on mood. They modulate neurotransmitters like serotonin and noradrenaline in pain pathways in the brain and spinal cord.
What about opioids in chronic non-malignant pain?
Their role is controversial and generally limited. For severe, persistent pain unresponsive to other treatments, slow-release oral opioids like morphine or oxycodone, or transdermal patches, fentanyl, buprenorphine, might be considered, but usually only under specialist supervision due to risks of tolerance, dependence, and side effects. Tapentadol is interesting as it has both opioid and noradrenaline reuptake inhibiting actions.
There's also mention of sympathetically dependent pain.
Yeah, conditions like complex regional pain syndrome, CRPS, often triggered by minor injury. The sympathetic nervous system seems to get abnormally involved. Treatment uses a mix of anti-neuropathic drugs, intense physio, and sometimes specific sympathetic nerve blocks like a stellate ganglion block for the arm.
Let's touch on interventional pain management for chronic conditions, beyond standard blocks.
Yes, this is for more refractory pain. We can do very targeted injections guided by imaging, like transforaminal epidural steroid injections for specific nerve root irritation causing sciatica.
What about nerve stimulation?
Things like 10S, transcutaneous electrical nerve stimulation, or acupuncture might help some people, possibly by stimulating endorphin release or modulating nerve signals via the gate control mechanism. For trigeminal neuralgia, while drugs are first line, procedures like microvascular decompression surgery, moving a blood vessel off the nerve, are replacing older destructive nerve procedures.
And the most advanced intervention mentioned is spinal cord stimulation, SCS.
Right. This involves implanting electrodes in the epidural space over the back of the spinal cord. These are connected to a small, implanted pulse generator, like a pacemaker.
How does SCS work?
It delivers tiny electrical pulses to the dorsal columns of the spinal cord. The idea is that this electrical input closes the gate to pain signals traveling up to the brain, replacing the pain sensation with a more pleasant tingling paresthesia, or sometimes blocking the pain without any sensation using newer stimulation patterns.
What was SCS for?
It's a recognized treatment for severe, intractable neuropathic pain, particularly failed back surgery syndrome, persistent leg pain after back surgery, or CRPS. NICE guidance supports its use. There's also growing interest in using it earlier, potentially improving outcomes.
Okay, shifting finally to pain control in malignant disease, or cancer pain. The goal here is quality of life.
Absolutely. Maintaining function, independence, and dignity for as long as possible. The framework for drug treatment is the WHO analgesic ladder.
Remind us of the steps.
It's a 3-step ladder based on pain severity. Step 1. For mild pain, non-opioid analgesics like paracetamol or NSAIDs. Step 2. If pain persists or increases, mild to moderate, add a weak opioid like codeine or tramadol. Step 3. For moderate to severe pain, switch the weak opioid to a strong opioid like morphine, oxycodone, hydromorphone, fentanyl. Note that pethidine isn't recommended for chronic use anymore due to toxic metabolite buildup.
How is morphine typically started and managed?
Usually you start with immediate release oral morphine solution given every 4 hours regularly. You titrate the dose up over a few days until the pain is controlled. Once stable, you calculate the total 24-hour dose and convert that to a modified release preparation, usually given every 12 hours, like MST Continuous.
What about pain spikes between the regular doses?
Crucial point. You must always prescribe supplemental doses of the immediate release opioid, usually 1/16 of the total daily dose, for the patient to take as needed for breakthrough pain.
And managing opioid side effects in cancer pain is key.
Mary. Nausea is common at first. Treat it with antiemetics. It often settles. Constipation, however, is almost universal and persistent. Patients on regular opioids need regular preventative laxatives prescribed from day one.
The chapter mentions equianalgesic potencies. Why is that important?
Summary box 23.11. It helps when switching between different opioids or routes. For example, knowing that roughly 6.6 milligrams of oral oxycodone is equivalent to 10 milligrams of oral morphine allows for safe conversion.
In very advanced disease, with limited life expectancy, sometimes neurolytic techniques are considered.
Yes, procedures designed to destroy nerves carrying pain signals. For example, a celiac plexus block, often using alcohol injected near the aorta, can give excellent relief from severe upper abdominal pain from pancreatic or gastric cancer.
And the most definitive one, chordotomy.
Percutaneous anterolateral chordotomy, a highly specialized procedure where a lesion is made using radiofrequency or heat in the spinal thalamic tract in the spinal cord. This tract carries pain and temperature sensation.
How's the effect?
It eliminates pain and temperature sense on the opposite side of the body below the level of the lesion. Very effective for severe unilateral pain, example, in one leg, resistant to all other measures.
And don't forget other strategies like radiotherapy or hormonal treatments.
Absolutely. Palliative radiotherapy is often very effective at shrinking painful bone metastases or tumor masses. Adjuvant drugs like corticosteroids can reduce swelling around tumors pressing on nerves, and hormonal therapies like tamoxifen can help control pain from hormone-sensitive cancers. It's all part of that multidisciplinary approach.
Wow. We have covered an incredible amount of ground there, from Ether Day in 1846 right through the evolution of safety with things like NCEP out, audits, and checklists, the shift to the perioperative physician.
Through the details of the anesthetic triad, airway gadgets from Godel's to video laryngoscopes, the nuances of relaxants like Rocuronium and Sugammadex,
Into the precision of ultrasound-guided regional blocks, the rules for LA toxicity, the differences between spinal and epidural.
and finishing with that complex world of pain, differentiating acute multimodal strategies from the biopsychosocial approach needed for chronic pain, understanding nociceptive versus neuropathic mechanisms, and the specific challenges of cancer pain management right up to interventions like SCS and chordotomy.
So key takeaways for you, the learner listening to this.
Master that triad. Understand airway management is paramount. Know your devices, especially the safety features of second-gen SGAs. Grasp the LA toxicity signs and the bupivacaine 4V rule. Appreciate why ultrasound is standard for regional. Know the difference Rocuronium Sugammadex makes. And clinically, really differentiate nociceptive pain, opioids, NSAIDs may work, from neuropathic pain, needs gabapentinoids, antidepressants.
That distinction seems absolutely fundamental. Which leads us to our final thought, something for you to mull over. We've heard how successful non-drug approaches CBT, mindfulness, exercise, the whole biopsychosocial model are in chronic pain.
Yeah, they're central to managing long-term pain.
So the provocative thought is this. What if we started integrating those psychological and rehabilitative approaches much, much earlier? Right from the immediate post-operative period for acute pain. Could proactively addressing the psychological distress, the fear avoidance, the deconditioning before discharge actually prevent some patients from developing chronic post-surgical pain in the first place?
If we're truly perioperative physicians, maybe our role extends beyond just prescribing painkillers. Perhaps actively managing the psychosocial factors right from day one could fundamentally change long-term outcomes for many surgical patients, preventing the transition from acute to chronic.
It suggests the future of pain management might involve strategies starting well before the patient even leaves the recovery room and long after the stitches are out. Something well beyond just the drugs on the trolley.
Definitely food for thought, a challenge for the future of perioperative care.
On that note, thank you for joining us for this deep dive into anesthesia and pain relief. We hope it's helped clarify this vital chapter. We'll see you next time.